As all of you knows, we begin with the basics. For diagnostic, confirm, exclude arterial disease, vasculitis, malignancy. As vascular assessment, it's mandatory to have the ABA, the venous ultrasound, the compression therapy optimized, the wound care optimized, and address contributing factors like edema, infection, nutrition, glycemic control, and mobility. The second step is optimize the compression and the local care. If already the patient is on compression, we can upgrade to multilayer compression system and adjustable Velcro wraps, and add leg elevation, and the patient has to walk, to do a lot of exercise, swimming if it's possible, and for wound, if the patient needs, we can do the debridement and treat the infection if it's present with systemic antibiotics and antimicrobial dressings. For advanced wound therapy, if no improvement after 4 or 6 weeks, we have the skin substitute, negative pressure wound therapy, growth factor, but is with limited evidence. To address for venous insufficiency, if ultrasound shows reflux or obstruction, for superficial venous reflux, we have the gold standard, which is endovenous ablation, laser radiofrequency, the sclerotherapy, open surgery. For perforator incompetence, the target is the ablation, and for deep venous obstruction, the venous stenting. Early intervention means faster healing, reduced recurrence. Tissue protection, it's very important for the patient to limit the skin damage, lower cost, and improve quality of life, less pain and discomfort. If we consider atypical causes, we can biopsy the ulcer. And for rescue therapy, with limited evidence, we can use hyperbaric oxygen therapy, conservative treatment. And to prevent recurrence for long term, it's important the weight management, lifelong compression stocking, mobility, leg elevation, and the patient education, skin care, and to observe the early symptom. For clinical practice, I have the 71-year-old female with chronic venous insufficiency, with hypertension, with a lot of comorbidities, with severe obesity. This is the result after 1 month. And we've treated the patient for 5 months to get this result. Another patient, 89 years old, with chronic coronary syndrome and history of colon cancer. He was treated on dermatology for long. After the wound secretion, we have Serratia. We treat the infection, and this is the result after 2 weeks. A 52-year-old female with hypertension, type 2 diabetes, obesity. This was the moment before intervention. She was treated previously in another department with laser ablation. I've practiced the crossectomy and the incompetent perforator, and this is the result for after 4 weeks. What about we don't have only venous ulcer and we have the mixed arterial and venous ulcer? This is a case with a mixed ulcer, 74 years old male, with chronic kidney disease, a long-term smoker, and after a PTA with balloon and debridement, treated the infection. This is the result after 2 weeks. compression alone is not enough in refractory cases. Early venous interventions, it means better healing outcomes. For refractory ulcers require multimodal approach and always reconsider diagnosis if the ulcer is not healing. Thank you very much, and we are waiting for all of you in Romania, in Timișoara, for the Congress of the Balkan Venous Forum.